So everyone, if you want to switch on your cameras, thank you for joining us today. We're starting off with Dr. Shapiro, who's the Director of Cancer Survivorship at the Tisch Cancer Institute. Here to talk to us about survivorship. Thank you very much, Dr. Shapiro.
You're welcome. I'm going to talk about survivorships, particularly in breast cancer. You're muted now. Can you hear me?
Yeah, we can hear you, and the slides look perfect.
Okay, so all right, disclosures. Survivorship is on the radar screen now, but is an afterthought and still not fully integrated into cancer care. The good news is the deaths are decreasing. This is a reflection of the death rate without mammography screening and adjuvant therapy. This is the effects of screening alone to decrease death rates. This is the effect of adjuvant chemotherapy, which is routinely applied to breast cancer patients. And this is the effect, the aggregate effect of, this is the aggregate effect of both. Deaths are decreasing, and that's the good news. Now, changing demographics of the population of cancer survivors. This is a 2021. There's about 20 million survivors in the world, in the US today. Most of them are over the age of 65. So the green bar is 65 to 74 years old. The purple bar is 75 to 84 years old. And the blue bar, the light blue bar, is 85 years plus. So in the coming weeks, decades, the survivorship is going to increase. And geriatric oncology and geriatric oncology survivorship is going to be a good field to get into. So what is it? It's empowering individuals to chart their own path to wellness after cancer treatment and having cancer. When does it begin? At the time of diagnosis, but functionally it begins at the time of completion of treatment. And why is it important? Well, I just told you there's 20 million survivors in the US, primarily breast, colon, and prostate, and there'll be 26 million by 2040. And everyone will touch, everyone in the medical profession will touch a cancer survivor. It's just so prevalent. In a 15-minute follow-up exam, do you have time to adequately screen for depression, discuss vasomotor symptoms, discuss sexual dysfunction, discuss bone health, discuss return to work and a financial answer? And the answer is no. So what are the various models of survivorship care? And this is a listing of the various models of survivorship care. And the NP and clinic model is what I think is the best model. Survivorship NP in a disease-specific site. NP is experienced with that disease and has access to disease site experts, which are in clinic alongside her. The other model is the PCP and oncologist shared care model. It's a good model if the PCP is introduced upfront as part of the treatment team. That's all I'll have to say on models of care. There's two aspects or dual aspects of survivorship. One is improved health behaviors. We call that the teachable moment. When there's a crisis, there's increased receptivity to behavioral change. And we're talking about not just cancer survivors, but anybody in medicine, who's dealing with these issues like increasing physical activity, weight management, healthy eating, smoking cessation, back to work issues. They're all part of this teachable moment. And there's the treatment-related aspects of survivorship care, common treatments, treatment-related toxicities such as peripheral neuropathy, fatigue, sexual dysfunction, pain, and the rare side effects such as anthracycline-induced congestive heart failure, leukemia and MDS, and so forth and so on. So there's a duality of survivorship care, and it's both are important. Survivorship issues the long-term and late effects of treatment, follow-up guidelines, duration of oncology follow-up, communication, which is key among providers, and knowledge of providers, both the oncologist and the primary care and mid-level providers. So this was an old survey done when Lance Armstrong was a good guy, and it's over 1,000 patients, and 70% of them reported that oncologists did not address and support dealing with secondary problems due to cancer. 30% of survivors reported that oncologists were willing to talk about secondary health problems. However, they didn't lack information to provide guidance. So that's a sobering statistics. This is a survey done a long time ago, but I think these numbers still held up today. Also part of the survey was a needs assessment. 53% overall reported secondary health problems, chronic pain, sexual difficulties, sexual dysfunction, relationship difficulties, fertility issues, fear of recurrence, depression, back to work, and 49, nearly 50% of patients reported their non-medical cancer needs were not met. So we have a lot of work to do in dealing with these survivors. Now I'm going to break this talk up into a series of vignettes that illustrate, I think, key points. And not all survivors, this is the first vignette, not all survivors have the same needs, and needs change over time. Okay. So this was a convenience survey of, let's say, okay, so OSU Medical Center is in Columbus, Ohio, and it's a white-collar town. Lots of insurance companies have their headquarters in Columbus, and it's economically advantaged. Other regions of Ohio, such as where the Holzer Medical Center is in Appalachia, that's economically disadvantaged. So here's the demographics, and you can see how Columbus, Ohio, OSU Medical Center, comparatively to Holzer Medical Center, and the per capita income, the poverty rate, the unemployment rate is all greater in these economically disadvantaged Holzer survivors. And here's another illustration. So the age was the same of the two populations. The majority of people were white, overwhelming majority. 2/3 of them were female. But look at the education. Greater than high school, only 27% of Holzer survivors had education greater than high school, and the median income under $40,000 was 63% of the survivors. Again, these are economically disadvantaged people. The results of the survey. Whereas if you're economically advantaged, you have time to think about exercise, healthy diet, and psychosocial concerns. If you're economically disadvantaged, you're concerned with primarily financial concerns, i.e., do I have enough gas money to drive to the doctor for my follow-up care? So this is a stark difference, and this reflects the difference of an economically advantaged group at OSU versus the Holzer group. So we asked another question in this survey. These are the various services dealing with fatigue, dealing with exercise, diet, financial concerns, support groups. And the amount of people that were referred to each of these services. But we asked another question. Would you go if you were referred? And nearly double in the green bars would go if they were referred. So this means even in our own communities, we don't know the resources available for survivorship care. The survey results translated into actions. You can read this, and all survivors don't have the same needs, and they change over time. The context in which a survivor finds themselves, who they are, where they live, what resources they have, their racial and ethnicity backgrounds, makes a difference in the perceptions of needs of the survivors. So, Vignette 2. The American Society of Clinical Oncology in 2006 initiated the Quality Oncology Practice Improvement Project. This is where practices from the community and academic medical centers across a wide geographic distribution across the country voluntarily send in their medical record data. And the questions, which you'll see in a minute, are based on published guidelines. In other words, the guideline is published, for example, smoking cessation, and its compliance with the guideline that is documented in the medical record. And COPE is a measure of the quality of care that we provide. So infertility guidelines were updated they originally published in 2006, they were updated in 2013 and updated yet again in 2018. They're for women 18 to 40 and men 18 to 50. And the key recommendations are discuss the risk of chemotherapy-induced infertility. And for appropriate people, discuss fertility options or refer them to specialists. So how are we doing? You can tell we're not doing well. So this is the infertility risks discussed prior to chemotherapy. In other words, documentation of you discuss the risk of infertility in a patient getting chemotherapy. It went from 20% to 35% in the fall of 2009 to the spring of 2014. Fertility preservation options discussed or referred to specialists. This was even poorer performance, 12% in fall of 2009 and increased to 22% or 23% in the spring of 2014. So survivors have unmet needs. The results of the fertility COPE project are the good news, or things are improving. The bad news is the majority are not having the discussions and not being aware of chemotherapy-induced infertility. Again, we have a lot of work to do. The third vignette is dealing with symptoms during cancer treatment, and these are the various symptoms of treatment, chemotherapy primarily, and I want to focus on Chemo Brain. Chemo Brain, our patients have coined this term, is a constellation of symptoms involving short-term memory, concentration, and language finding difficulties. Chemo Brain is very difficult to study because some of the same symptoms that cancer survivors have can affect cognition. Fatigue can affect cognition, depression, anxiety, and stress, pain medications, other physical illnesses. What's key is most of the studies don't have a pre-chemotherapy baseline of cognitive dysfunction. The few studies that did have a pre-baseline chemotherapy baseline suggested that breast cancer patients have cognitive dysfunction before they get chemotherapy, and that's interesting and unexplained, but that's an interesting fact. And all of the above complicates the design and interpretation of the results of the studies. The patterns of cognitive problems may come and go. We think 15 to 20% are really affected. It's worse when multitasking, under pressure, and when you're fatigued. This is a meta-analysis of the trials published in 2015, the cross-sectional trials and the prospective. And these are the various fields of cognitive domains: attention, executive function, language, long-term memory, motor function, processing speed, short-term memory, and visual spatial function. And you can see the cross-sectional studies were more positive. The left of the line indicates cognitive dysfunction than the prospective studies. Again, this is all in the context of these studies being very difficult to do. Cognitive function tends to improve over time. This is a measure of cognitive function where the higher numbers are worse cognitive function, and patients improve over time. And these are general quality of life questionnaire which show improvement over time. But yet 15%, 20% of them still complain of this chemo brain constellation of symptoms. So we're not always measuring what we think we're measuring because the patients complain, and maybe we're not asking the right questions on these standardized questionnaires. Probably the most compelling evidence is functional MRI evidence. And these are identical twins. One has breast cancer and one doesn't. One is getting chemotherapy. And you can see the chemotherapy, there's the first part of the brains, there's a different pattern of activation of various brain centers and off functional MRI relative to the non-twin, the twin that didn't get chemotherapy. So a model possibly in this cartoon is the possible determinants of chemo brain or the treatment characteristics. Genetic susceptibilities plays a big role, cytokine imbalance, and hormonal factors. These are the mechanisms. The primary outcome is chemo brain. It's amplified by psychological stress and other health-related problems related to chemotherapy like anemia, and it ultimately reduces quality of life. How can you study this? How can you really study this? Animal models given human doses of chemotherapy. You assess behaviors, you autopsy their brains, and develop a hypothesis that can be tested in humans. And translational is a two-way street. Translational research is a two-way street. We're used to thinking of it solely from bench to bedside. But bedside to bench is an equally valid way of thinking about translational research. Observations at the bedside, Chemo Brain, can be brought back to the lab and studied in animals. So there are validated tests in mice. Depression is a swim test, and the mice spend more time floating if they're depressed. And don't ask me how they got to this, but they got to it. Anxiety. Mice prefer close spaces. Less time spent in the open suggests anxiety. And learning, cognitive dysfunction, a maze. This can be created, and the latency of which the mouse solves the maze can be a measure of cognitive dysfunction. So you do an experimental design, you take mice, inject them with the equivalent doses, or 75% of the human dose, and you do these tests. And what do you find? You find after chemotherapy is injected, they increase their floating behaviors. They spend less time in the open. This is the chemotherapy-treated mice versus the vehicle or control mice, spending almost half the time chemotherapy-treated mice. And you measure cognition by a maze, and they still can learn, these mice, but there's a delayed learning curve. So they are delayed in learning. So when we autopsied these brains, we found neuroinflammation. And that led to neuronal changes, which we think manifested as behavioral changes. That's only a hypothesis, but it stands to reason. And we found activated microglial cells and M1 macrophages promoting inflammation. A correlate to this is reduced dendritic branching and spinal density and increased cytokines we found. So chemotherapy induces sickness behaviors in mice that correspond to common chemotherapy-related problems, such as depression, anxiety, and cognition. Minocycline, the antibiotic, crosses the blood-brain barrier and prevents this in mice. Humans' blood-brain barriers are permeable to minocycline. We generated a hypothesis: microglial activation and neuroinflammation would occur. A clinical trial designed to test this hypothesis was formulated using minocycline and PET scans to measure activated microglial cells. Now, I wish I could show you the results of this study, but it never got off the ground for a variety of reasons, not the least of which it didn't get funded by the NCI. But that's an example of clinical research in survivorship. Chemo Brain is real, but difficult to study. What is the baseline and how we measure it? We think it occurs in 15 to 20%. Imaging research is the most compelling part of Chemo Brain. Structural and metabolic changes in the brain. Genetics is a likely determinant of who gets it. And additional research is, of course, needed. Do I have time to go on for the last section?
Yeah, of course, until 2 p.m.
Okay. So cancer-related bone loss is the final topic I'll discuss. And all these cancer treatments listed here and here and here and here contribute to hypogonadism. Estrogens and androgens are protective against bone. You depress estrogen and androgens by these various treatments, you get elevated bone turnover, which leads to bone loss, and some people will fracture or have osteoporosis. I underline some people, because everyone loses bones, but only some people get into osteoporosis. So osteoporosis can be thought of as an equation. It's the peak bone mass generated by age 29 versus the bone loss related to age, and women have the heightened risk of menopause as estrogen deprivation. It's totally influenced by genetics, but a few exposures like smoking, lack of exercise, alcohol, and medications are modifying factors. We measure bone mineral density by the central gold standard DEXA scans, measuring the hip, femoral neck, and total hip. Measuring the spine and total hip and femoral neck. And the output on the test is the T-score, which is nothing more than the number of standard deviations by which the bone mass falls above or below the peak bone mass for a healthy 30-year-old female. For every one standard deviation decrease in T-score, the relative risk of fracture increases 1.5 to 2.5 fold. And T-scores define on the DEXA scans the normal range, which is above -1, like 0 plus 1. Osteopenia is defined as -1 to -2.5, and osteoporosis is lower than -2.5, like -3, -3.5, and or having a fracture. So there are nomograms that predict 5-year fracture rate based on age and T-scores. So a T-score of 3 in an 80-year-old predicts about a 9% risk of fracture of the hip in 5 years. So there are good nomograms to correlate fractures with T-scores by age. So what is the source of estrogen in a premenopausal woman? Obviously, it's the ovary, but chemotherapy causes early ovarian failure or early menopause. This is a study from Journal of Clinical Oncology, where both the combination of chemotherapy and hormonal therapy, standard treatment in breast cancer, if you're age 60, age 40, there's a 60% risk of developing ovarian failure, permanent ovarian failure. These are some studies that are done that highlight the magnitude of loss. The two greatest magnitude in the spine, the blue bars, are those studies that took careful pains to prospectively identify the women with chemotherapy-induced ovarian failure. These studies took all comers, those with chemotherapy-induced ovarian failure and those that didn't get into chemotherapy-induced ovarian failure. There's about an 8% loss at the lumbar spine at 12 months, which is a highly significant loss of bone. What are the sources of postmenopausal estrogen? Well, it comes from the adrenal glands that produce androgens, that gets converted to estrogen by the action of aromatase. And the aromatase inhibitors, letrozole, exemestane, and inostrozole, are selective aromatase inhibitors that inhibit this enzyme and functionally cause a decrease in estrogen levels. Now, studies have compared aromatase inhibitors to tamoxifen, and always there's this highly significant rate of increased fractures in AI-treated patients. The one exception is the MA17 study that gave everybody 5 years of tamoxifen and randomized after 5 years to letrozole versus placebo. That's why the preserve of bone in the tamoxifen-treated group is responsible for the non-significant value in terms of fracture rates. The two classes of drugs we have to treat osteoporosis are zoledronic acid, which is an osteoclast inhibitor. It's IV administered. Toxicities are renal dysfunction, arthralgias, fevers, and osteonecrosis. Osteonecrosis is a rare but serious toxicity of bisphosphonates and the rank ligand inhibitors denosumab. It occurs in about 1% of patients, and it's dead jawbone. The reason it's so devastating is there's no treatment for it. So you want to avoid it if you can. Denosumab is Prolia. It's a rank ligand inhibitor. It's sub-Q administration, and the toxicities are hypocalcemia and, I said, osteonecrosis. How do these drugs work? This is a cartoon of zoledronic acid, and it inhibits the differentiation of precursors, hematopoietic precursors, all the way down to the activated osteoclast. Rank ligand is secreted by osteoblasts, and OPG is a decoy receptor for rank ligand, but these are rank ligand inhibitors, or denosumab, which is an antibody to rank ligand. So it serves to decrease bone resorption. I'm going to give you an example of some trials. The Z-FAST trial, which is over 1,600 postmenopausal women treated with letrozole. They got zoledronic acid right away every 6 months for 5 years, or delayed zoledronic acid when the T-score dipped to below 2. Here are the results. As you might expect, the upfront treatment preserved bone mineral density, whereas the delayed zoledronic acid lost bone mineral density in the hip and spine. But here's a very important fact. Only 13% of the delayed group received zoledronic acid, and the fracture rates were 1.3 versus 1% for delayed versus immediate zoledronic acid. That means that only 13% over 5 years needed zoledronic acid. So everybody loses bone. But some people fit the criteria of treatment based on T-scores. And not everybody who gets on aromatase inhibitors needs a bone strengthening medicine like denosumab or zoledronic acid. This is a study of denosumab. The 3,400 over 3,400 postmenopausal women received aromatase inhibitors with 4 years of follow-up. and look at the fractures. Denosumab 92, placebo 176, a highly significant hazard radius of 0.5, 95% confidence intervals, highly significant. So denosumab works and prevents fractures in a postmenopausal population. What about vitamin D and vitamin D deficiency? Well, calcium and vitamin D reduces fractures, but vitamin D deficiency is common. And in a recent study of breast cancer survivors, showed 76% of them were vitamin D deficient. And there's no consensus on measuring serum vitamin D on a patient with your treating with aromatase inhibitors. Some people will measure it routinely. I measure it if there's osteopenia or osteoporosis on the initial DEXA scan. So how well are we doing? Well, there was a study that took 260 women ages less than 50. 34% have chemotherapy-induced ovarian failure. Do we recommend regular exercise? 72% of patients in this study were recommended regular exercise, 57% calcium and vitamin D, and only 40% got regular DEXA scans. So again, we have a lot of work to do in bone health of breast cancer survivors. So what do you do? You smoking cessation, alcohol reduction, take plenty of calcium and vitamin D, DEXA scans, and you only treat based on the DEXA scan. And I said it again, but it's worth saying now, everybody loses bone, but not everybody needs a bisphosphonate or a ligand inhibitor to treat osteoporosis. Health professionals should be aware of the bone loss through treatment, familiar with recommendations on bone health and DEXA scans for screening. Recommendations for bone health, calcium and vitamin D, exercise, reduce smoking and alcohol, promote overall health as well. And we shouldn't lose the forest from the trees. And that's my presentation. Thank you. I'd be happy to take questions.
Thank you so much for that, Dr. Shapiro. A really great talk. If anyone has any questions, you can feel free to unmute yourself and ask away. You can also post in the chat and we can read them out.
Hi, I have a question. Dr. Shapiro, I'm Sophia, I'm a PGY3. Just wondering, for example, on the subject of bone health, how does the numbers in terms of how many people are getting screened and tested, screened and treated, are compared to the numbers in the entire population? Meaning, do you think in the cancer survivor population there is more need, but the issues with getting to these people are the same maybe as the issues of getting to the entire population, or these populations are especially difficult to get to?
Yeah, so I think in answer to that question, an osteoporosis screening for non-cancer patients, women, for example, begins at 65. It's every 2 years. But breast cancer patients, for example, who go through early menopause, we screen them at younger than 65. We screen them, and we screen them whenever they get on bisphosphonate, get on AIs, for example, aromatase inhibitors. So osteoporosis is a global problem, as you know, but it's particularly important in cancer survivors who have treatment but a risk for fractures decades later. So osteoporosis, I'm thinking that in general population isn't too well integrated, although it's better than the cancer survivorship population. But does that answer your question?
Yeah, sort of. Yeah, thank you.
Okay.
We also have a question in the chat from Kirtana, one of our PGY2, saying, thank you for the lecture. Is there a recommendation to test bone mineral density prior to starting chemo after a certain age or with certain cancers or treatment regimens?
So prior to starting chemotherapy, in young patients, premenopausal patients, we don't start DEXA scans prior to chemotherapy because they're, by definition, closer to their normal menopausal age. Say a woman is 45 and getting chemotherapy. We don't test her before chemotherapy, before she gets chemotherapy, but we test as soon as she's done with treatment to reflect the bone loss, if you will, of the chemotherapy-induced ovarian failure or menopause. So we pay attention to these women and test them every 2 years. We encourage weight-bearing exercise, calcium and vitamin D intake. We rule out secondary causes of bone loss like hyperparathyroidism, which is not uncommon, or thyroid disease, and we follow them closely. And we have a FRAX nomogram. FRAX score is it's endorsed by the National Osteoporosis Foundation, and it puts in risk factors and a T-score of the femoral neck, for example, and you get a probability of fracture in the next 10 years. And a 3% probability of hip fracture or more is indication for bone strengthening like zoledronic acid or Prolia. 20% or more major osteoporotic fracture is indications for these drugs. So we follow these patients, but I don't get DEXAs before chemotherapy.
Thank you so much, Dr. Shapiro. So if there's no more questions or comments, we can probably leave it there for now. But thank you so much again for your time. This is great.